Welcome to Beyond the O.R with Dr. Kevin Brenner. I'm a board-certified plastic surgeon in Beverly Hills. I want to take you beyond my world of plastic surgery, diving deep into exciting hot topics and delving even deeper into compelling characters that I've met along the way. We'll be talking with attorneys, actors, comedy writers, Navy SEALs, and many other fascinating and inspiring people with truly intriguing stories to share. So let's jump right in. Welcome back to Beyond the O.R. Today, in honor of May, which is Skin Cancer Awareness Month, we have with us a dermatologist and Mohs surgeon, and more importantly, friend of mine and colleague, Dr. Andrew Breithaupt. Welcome, Andrew.
Thank you guys for having me.
Dr. Breithaupt, welcome. You earned the title. So today we thought it would be a good idea to talk about skin cancer. There's so much to know. You definitely are the expert. I mean, you know, I do take care of a lot of skin cancer, but you're like in the trenches of skin cancer.
Sure.
So wanted to get into that. So first off, for our listeners, for our viewers, I wanted to kind of tell them, or have you tell them rather, about your training, right?
Sure.
So a lot of people, because they confuse it with me, so I know they must confuse it with you, don't understand what it takes to A, become a dermatologist, and B, become a Mohs surgeon, which is what you do, right? So can you maybe explain from med school, right? We both went to med school, and then after we graduated med school, you did what?
So after medical school, I did a dermatology residency, which is 4 years of training specific to dermatology, encompassing all aspects of the field, general dermatology, pediatric dermatology, and then some aspects of the surgery that ultimately I specialized in. After residency, most doctors will go into practice or take their boards, then go into practice. A small subset will pursue a fellowship, which is further subspecialization within your specialty. I did a Mohs surgery fellowship, which is an extra year of surgical training, really focusing just on the diagnosis and the removal and the reconstruction of skin cancer patients. And after that, I then went into practice.
So, and you're in practice, I forgot to mention, in Dermatology Associates, which is a huge derm group, which is right across the hall from my office, which is how we met initially.
Correct.
And we've worked together many times. We share a lot of patients. Explain for viewers, I know this, Elizabeth probably doesn't understand the detail of it. So explain for Elizabeth, what exactly is Mohs surgery? And that's M-O-H''S.
Yeah, it doesn't
It's
stand
not like
for, it
Mo,
doesn't
it's not
stand
like
for
Mo
anything.
and Larry,
it's not like Mo and Larry or anything like that from Three Stooges. So Mohs surgery is a specialized technique for removing primarily non-melanoma skin cancers, primarily of the head and neck. The main advantage of Mohs is it's tissue sparing, so we can kind of get the job done, removing as little healthy tissue as possible. And it involves doing the lab work more or less in real time. So traditionally with a lot of surgeries, or if you've been to your dermatologist, had a biopsy, the doctor will take a small piece of tissue and they'll call you a week later and let you know the diagnosis or if they got it all. With Mohs surgery, we use something called frozen sections, which means we have the lab and our lab techs in the office, and so we can get the results within 30 minutes to an hour. And so it's primarily used for non-melanoma skin cancers, which most people don't understand are actually more common than melanoma. And so we're dealing mainly with basal cell carcinomas and squamous cell carcinomas. And we do it all in the office, all under local anesthesia. We remove a portion of the tissue, but with very little extra margin or extra tissue, and then we test it while the patient waits. And if there's still some cancer remaining, we can take a little more and test it again until we're sure the patient's clear.
Okay, well, I have a follow-up question.
Sure.
In Dr. Brenner's office, I'm sure you've seen a lot of women with breast implants are starting to get squamous cells. Is that how you pronounce it?
Squamous cell, yeah.
Squamous cell. Okay, so for me, layman's terms, I had a squamous cell, right? Correct? That's how you say it.
Right.
And they kept freezing it.
Yeah.
When is it appropriate to not freeze it anymore and actually cut it out? Because Dr. Brenner's like, why don't you just cut it out instead of keep freezing it?
It's a great question, actually. And I I get that question a lot because oftentimes patients who come to me for surgery have already seen their dermatologist and had a biopsy to kind of prove what's going on. But it's not uncommon that they will have it frozen or treated with liquid nitrogen once or multiple times prior to seeing me. Liquid nitrogen or freezing tissue is not particularly appropriate once you know it's a squamous cell carcinoma. That treatment is usually used either for completely benign lesions like warts and things like that, or a very common lesion called an actinic keratosis, which we consider sort of a precursor to squamous cell carcinoma.
Okay.
And the differentiation between a pre-cancer versus a thin cancer versus an invasive cancer, it's all atypical or damaged cells, and it really, the differentiation is how thick that change is, how thick in the skin or in the epidermis that atypia or that damage is, with the pre-cancers being partial thickness or very thin, and then cancers being full thickness or invasive.
Okay. Okay.
Like how deep into
So
the
I should
the skin.
just have it cut out instead of keep freezing and freezing and freezing.
If you knew it was a squamous cell carcinoma from the word go, yeah, you
I
probably
do.
go. A lot of times it's being frozen because the diagnosis hasn't been accurately determined because a biopsy hasn't been done.
Okay.
So you're kind of making a clinical diagnosis versus a pathologic diagnosis.
They scraped
They
it.
did, and they knew. So
Okay, so I need to cut it out.
yeah.
He's sending you a bill for this.
Yeah.
Just so you know.
Hey,
Hey, we have to sign a HIPAA,
people are in my
a little
situation.
HIPAA waiver here too. Right? Yeah.
Yeah, I find that a lot of general
Tons.
dermatologists
Yeah, tons.
just they freeze off
Tons.
Everything.
lots of stuff, and then it's like I've been watching this for 2 years and it's still.
and I get it, and I will tell patients the same thing. You know, the liquid nitrogen is kind of the first line of defense, right? It's easy. It doesn't involve a scalpel or stitches or downtime or anything like that. So if you can get rid of something easily with freezing something, great. You don't want to have to see someone like me or see someone like Kevin to put you all back together.
Right.
But if something is frozen multiple times and it continues to come back, your skin's trying to tell you something. And I'll
Okay.
tell patients, you know, if your doctor's frozen, doctors get busy, they don't necessarily know exactly what they've done every time they see you. So if something's been frozen 2 or 3 times, it keeps coming back, say, hey, you've frozen this before, maybe consider having it biopsied.
Perfect.
So you'll do the Mohs excision is really what Mohs
Correct,
is
yeah, yeah.
the excision
Yeah.
of the tumor.
Correct.
You'll do that in real time, and sometimes I'll pop over to the office and there's like 8 patients sitting there with bandages all over
Yep.
their heads, and you'll do one, you do the next one, and move
Yep,
on,
yep.
and then once everything's clear, part of your training is to do the reconstruction.
Correct.
Also part of my training.
Correct.
Right?
We have very
Right.
overlapping training.
But like that's, I mean, you do a zillion of them all
Yeah,
the time.
yeah.
It's a fraction of what
Yeah,
I do. I think
yeah.
I usually just get the really, really hairy ones.
Correct.
Yeah.
Yeah.
And so that's kind of what the Mohs surgery aspect of it. Like there's the Mohs excision, and then there's the reconstruction aspect.
Correct.
That's where kind of the blending of the dermatology, Mohs surgery, plastic surgery techniques, that's all the training coming in real time. And you'll do that actually under local anesthesia for
Yes.
most of them.
Yes.
And the hairy ones we'll put to sleep and do.
Yeah,
in the
I mean,
operating room.
so, and this is common in medicine. A lot of specialties have overlapping training, but our fields overlap really in the reconstructive aspect, and the bulk of your training when you're doing that fellowship year that I talked about for myself at UCLA and how we train our fellows, the bulk of that is reconstruction, from what we consider simple reconstruction, kind of just sewing things together, line to line, to more advanced things like flaps and grafts. And 99% of that we're doing in the office under local anesthesia. I mean, we can use some like oral sedation if we need to. But for the most part, for patients' recovery and ease of everything, we're able to do it the same day that we've done the skin cancer removal, and just sort of a continuation of that removal with a little bit more local anesthetic.
Awesome.
And for the viewer, what a flap and a graft is, quick definition. We've talked about this before in reference, I think, to breast reconstruction.
Yes.
Similar stuff. But a flap is a piece of tissue that carries its own blood supply. So you can take skin from one area and kind of rotate it around. In the case of Mohs surgery, it's from the face. So like Dr. Breithaupt and I both will try to find the most cosmetically
Pleasing.
appealing way to do it on the face.
Yep.
On the body, it's not as critical, but on the face, you want to kind of blend your incisions into natural creases and
Yep.
natural lines and stuff. and there's a real art to it.
Yeah, when patients will always ask me, is this going to give me a scar? Should I see a plastic surgeon? Will that give me a scar? I tell them the same thing. When anyone takes a scalpel to you and removes something, no matter who does it in the world, you will always have a scar. Our job is to try and find ways to blend that scar, to hide that scar, to make it look natural, and as it heals, it sort of fades into the background, okay? And so a lot of the way we do that is we all kind of get wrinkles and little lines on our face over time, and they're relatively predictable based on facial anatomy, so we try and use those to our advantage when we design these reconstructions so that as the redness and the swelling of the initial healing fades away, it kind of just is lost in the background noise.
Awesome.
So now I'm sensing the pattern. When someone tells you that they don't want a scar at all,
Yeah.
that's when you send them to me.
Yeah.
There's
only one guy.
So that I can break the news to them.
This one guy. He's right down the hall, by the way.
I'm like, really? Another landmine. Okay, so Mohs surgery really primarily for basal, B-A-S-A-L,
not the spice,
B-A-S-I-L, basal cell carcinomas, which is one cell type in the skin, and squamous cell carcinomas, which is another type of cell in the skin. It's primarily for that. There has been some studies, there have been some Mohs surgeons who will do Mohs on pigmented lesions.
Certainly, yeah.
But that's a little bit more controversial, a little bit more difficult, and not quite as.
It's not totally. I wouldn't say it's necessarily controversial. It's not fully widely accepted, and this kind of gets down into just the weeds of how the tissue is processed and the pathology and the interpretation of the pathology. It's pretty well accepted that the way we do the tissue processing in the office with these frozen sections is acceptable for the basal cell and squamous cell carcinomas. With the pigmented lesions, and we're primarily talking about thin melanomas here, it can be a little more difficult to do that lab work in the office, but there are some newer techniques involving some different staining techniques that have helped people. So it's done. It's not the most widely accepted way, though, to treat certain pigmented
And
problems.
the other reason, at least in my opinion, why it's sometimes is not a great idea. With a basal cell and a squamous cell carcinoma, if you miss what we call a satellite lesion, like a cancer cell, everything looks like it's clear. Like you look at the perimeter and it's clear, and there happens to be a little ways away another tumor cell that you don't see because it just doesn't show up, right? If that happens with a basal cell carcinoma, it's a slow growing process. It's a slow growing tumor.
Yeah.
With a melanoma, if you miss a tumor cell, it's potentially deadly, right? Because it can just sit there, continue to grow, and then metastasize and grow. And people have died from metastatic melanoma, which is why I have a very low threshold for taking off. By the time someone comes in my office, I'm like, let's just take it off.
Yeah,
if it's
absolutely.
pigmented, it's coming off.
Yeah.
So, which brings me to, there's a very common acronym that we use, or that dermatologists use, and that has now become sort of public domain about when do you know if, everyone has moles, right?
Correct, yeah.
Everyone's got some pigmented lesions.
Yep.
99% of them are probably benign,
Yep.
right? So how do you determine whether something is worth worrying about, right?
So,
because for instance, last year I had something on my arm, right? And I was like, I'm like, that really looks different.
Yeah.
I look at my arms every day because I'm scrubbing and stuff.
Yep.
And so I went into Dr. Weiss, one of your partners.
Yeah.
And I'm like, Steve, I don't like how this thing looks. He's like, I don't like how it looks. And he punched it. And sure enough, it was pre-melanoma.
Okay.
Right? It wasn't.
It was atypical.
It was severely atypical.
Yeah.
So how does that was me, and it was sitting there, and I just happened to notice it. How does the average person who's not trained to look at these things?
So we'll go through the acronym first, because that's what most people know, which is the sort of ABCDE of pigmented lesions. And just to differentiate what we were talking about with the Mohs, we were talking about non-melanoma skin cancers, basal cell and squamous cell carcinomas. Those are actually far more common they look more or less pretty different than melanomas. We're talking about pigmented lesions, so like moles, dark spots on your skin, whereas these non-melanoma skin cancers, they tend to be kind of red, scaly, broken down skin, things like that. So with melanomas, we talk about A, B, C, D, E, A being asymmetry, okay? And so just you're sort of asymmetrical mole, right? And in general, and this is not even specific to skin, benign lesions or normal growths in the body tend to be symmetrical, okay? Whereas malignant growths... Circular, yeah, even if you will.
Right.
Malignant growths are growing sort of following the path of least resistance, so they tend to be asymmetrical. Border is B, and essentially an uneven or like a scalloped border as opposed to a nice round border would be another warning sign. Color is C, which is not necessarily, it's basically color variation. So if one portion of the growth is brown and the other's jet black and the other's pink, all within the same growth, that's something to worry about. D is diameter, which would be, we usually use 6 millimeters as the sort of threshold, if you will. And that's approximately the size of a pencil eraser, just for sort of estimation. That's not to say that all moles bigger than 6 millimeters are necessarily melanomas. These are just gauges that you can kind of go by. And E would be evolving, basically changing. And a lot of times that's probably what you may have noticed with your arms. Like, God, I've looked at this thing for 30 years and it hasn't really changed much. And it looks different than the last time I kind of took stock of it. And that's where we'll get most of our self-referrals, if you will. The patient comes in and say, I've had this mole since I was a teenager, but it looks different. And so we put a lot of stock in that, and oftentimes we'll biopsy those lesions.
And so this was somewhere that I could see, right?
Yeah.
And most of your body, your entire back of your legs. But, I mean, we get moles everywhere. Most people can't see all. I mean, you can see everything on your front, but it's really hard to get a really clear picture of it. So, which leads me to, like, I diagnosed this because I saw it.
Yeah.
Right? If this was on my back,
Yeah.
it may still be growing on there and could have developed into melanoma.
Mm-hmm.
So that leads me to our next topic, which is prevention.
Correct.
Right? So prevention is great because it prevents disease. It is probably going to reduce your business a little bit, right?
Yeah.
No, but the goal is
Plenty out there.
right. Yeah. Ounce of prevention
Correct.
is worth a pound of cure, right? So, what's the best way for the average patient to kind of monitor things?
It's a really good question. I think it's kind of a loaded question because if you think about
It was intended
the
to be
preventative, I think it's the U.S. Preventive Task Force guideline, right, where we know women get their mammograms starting at 40, right? The colonoscopy just went down to 45. PSA screen. We have, for some cancers, we have set screening guidelines. There is not one still for skin cancer screening. There's not one that's hard and fast recommended by the sort of U.S. Preventative Task Force.
And why is that a problem? If it's a problem, or is it not?
There's just not a consensus because I'll have patients, I'll have a parent, say they're in their 40s or something, and they're coming to me for a melanoma or they're coming to me for a basal cell, and they say, at what age should I get my kids screened? I don't have a firm answer on that. Could you take your 7-year-old in for a full body mole screening? Of course you can. Is the predictive value of that extremely low? Yes. Skin cancers are exceedingly low in children, especially non-melanoma skin cancers. Right. They tend to almost always be a disease of the older because I'll get into the genesis of them, but it's cumulative UV or cumulative sun exposure for the most part. So we just don't have a perfect answer. So self-screening is important, right? You look at yourself in the mirror, you see the funny mole, you see something changing. But a professional screening is, of course, extremely important as well because dermatologists, while those ABCDE guidelines sort of are in our head, we have just years of experience of seeing thousands of patients and tens of thousands or hundreds of thousands of moles. So there's more of an intuition there as well. So if you're at all worried, there's lots of dermatologists around. Try and get an appointment for a full body screening. That's where you would start with the prevention. We can get into the lifestyle and sunscreen and all that stuff if you want in terms of things you can do in your day-to-day life to prevent the development. But if you're talking about prevention from a diagnostic perspective, self-screening and see your dermatologist. And if you get one full body visit, your dermatologist will usually tell you, well, or they can tell you if you ask, you're low risk, you're high risk, maybe do this once every few years, or hey, you might need to see me every 6 months, or even every 3 months if you've been diagnosed with certain skin cancers in the past.
And
Go ahead.
carry on.
I have a question.
Yeah.
Does skin color, one, have anything to do with a higher risk of melanoma?
Yeah.
And also, I'll get back to the other question because I can't remember what it is right now.
No.
Do you know anything about early onset dementia?
That's the neurologist.
Oh, that was.
That's the other guy. So skin color is very important in terms of your risk factors, if you will, for the development of skin cancer. In dermatology, we have something called the Fitzpatrick scale, which is a 1 through 6 scale that more or less correlates to how pigmented you are. It really, if you look at how it's graded, it's can you tan, do you burn, you never tan, you never burn, things like that.
I'm a 1.
You're a 2.
I'm
You're
a
kind
2.
of a 2. You're like a 2 to 3. So on one scale, on the 1 you have extremely pale Northern European, very light eyes, can't get a tan, sunburns all the time, and 6 would be very, very dark skin, almost impossible to burn, dark eyes, things like that. So Fitzpatrick's types 1 and 2 are far more prone to skin cancers than say 4, 5, and 6. And the other thing that actually I find to be a stronger sort of gauge is eye color. So if you look at demographics and statistics, light eye color correlates with a significantly higher incidence of skin cancer.
Really?
It's not uncommon that I will see skin cancers, both melanomas and non-melanomas, in Hispanic skin or darker sort of East Asian skin, but very often the patients will have green or blue eyes. Even though their Fitzpatrick type may be like a 4, their eye color is lighter.
Follow up with that, my girlfriend had melanoma in her eye and had to have her eye removed, which I didn't even know that was possible.
It's quite rare, but it's very morbid and can be very mortal.
It can occur actually in your retina. It can occur on any mucosal line. I mean, you can have.
No idea.
It's not unheard of to have it like in the nail bed of your toes or your fingers.
Yeah, the Bob Marley is the classic story
or even,
with that.
even on in the anal skin. You can develop melanoma.
And that's what I want to talk really quick. What should you expect when you get a screen? Let's say you go to your dermatologist. Because I've had dermatologists that I've been to and I don't get naked and they just kind of superficially look. But then I had a girlfriend that her dermatologist just completely checks everything and she had a melanoma in between her in her glutes. And in her glutes inside like her 2 cheeks. So if the doctor wouldn't have been thorough. So what do you expect to get a good screening? What should that look like?
It's going to vary doctor to doctor, honestly. And some patients are comfortable with a very invasive exam, and some may say, hey, I'm going to keep my underwear on and just kind of check me head to toe. Your basic screening, you're going to be brought into the room and at least asked to put a gown on. A lot of patients will kind of make the decision at that point, do they want to take their underwear off or leave their underwear on? And so if they're not comfortable with that. But yeah, a complete screening, I will often start in the scalp, really comb through the hair. Non-melanoma skin cancer, squamous cells in particular, are very, very common on the scalp. Even if you have, for men who've lost their hair, they're extremely common. But even for people with a full head of hair or women, with women, we'll often see them in the part line. Say you've parted your hair in the same position for 40 years. It's basically like you're bald on that one section. It's just getting sun all the time. So we'll start with the scalp. We'll work our way down, a quick assessment of the mucosal area, although sometimes your dentist will assess you as well as part of your screening there. And then all the way down to in between the webs of the toes, because like you brought up with your friend there, it can happen anywhere.
Okay.
At what point do you say, like, I need to be photographing this person and like doing comparative photographs
Yeah, so
year to year?
you're talking about mole mapping, which is done. We do it in our office. It's not commonplace. That would really be for a high-risk patient. There's a syndrome, if you will, that we define as what we call atypical Nevi syndrome, and there's a few different definitions of this, but it's your patient, your kind of moldy patient. So you're looking at a patient and they have 50, 100, 150 moles on their body. Oftentimes, several of those moles have been biopsied and been atypical, or what you described on your arm as kind of pre-melanoma. They might have a first-degree relative, a brother, sister, mom, dad, who's had a melanoma, or they've had a melanoma in the past. That's a patient who may benefit from total body photography, and we do that, totally. You have little protection down here, but totally standardized photography. And then there are computers that will actually track those photographs year to year and can identify possibly changing lesions. And this is actually, that software is several years old. I'm very curious with machine learning and the ability to recognize images well, where that sort of technology will go. I think that will evolve pretty quickly in the next few years.
It's like the chat GPT
exactly.
skin cancer.
It's called, the robots are coming for everybody.
So, okay, so obviously prevention, I would say 9/10 of it is checking, monitoring, and then avoiding sun exposure, right? I mean, we know that that UV exposure is almost a prerequisite for most skin cancers, right?
Although melanomas are probably 50-50 if I had to put a number on it, genetics versus sun exposure. We know that non-melanoma skin cancers, your basal cells and your squamous cells, genetics play a role in everything, right? I mean, we know that. You can't fight your genes, you can't change who your parents were. Your genetics kind of set you off on a course from the beginning, and then environment triggers things. So if we think about like lung cancer, right? Some people can get lung cancer without smoking, and some people can smoke their whole life and not get lung cancer. And then there's the subset where they, from smoking do get it. It's a combination of genetics and that environmental trigger. Well, the same things for skin cancer. There's going to be a genetic predisposition and the environmental trigger, which is primarily sun exposure. And for your non-melanoma skin cancers, it's a cumulative sun exposure over one's lifetime, which is why we tend to see those pop up when patients hit their 40s, 50s, 60s, 70s. Melanomas, yes, that tanning and things like that do come into play, but you can get a melanoma in your teens, in your 20s. You can very much get it in a non-sun exposed area like you were discussing with your friend there. So that's a little trickier there. But overall, in aging prevention and all that stuff, the sun is not really your friend. You don't have to be a vampire. I live at the beach, I like to surf, but you have to be kind of smart about it.
So other than staying indoors all day, I mean, we're in Southern California. I grew up here. We're outside. I've been outside, with the exception of my 13 years in the Midwest. I've been in the sun just about every year.
It was good for
Wisconsin and Chicago. It was good for my skin cancer risk, but not good enough apparently. So apart from that, sunscreen. Right? Sunscreen, hats, covering up when you're outside. What are the best strategies?
Sunscreen, hats, and then don't forget just kind of lifestyle choices or time of day is very important. Again, enjoy your outdoor activities. Play tennis, golf, surf, run, whatever. Maybe not at noon in August. I have tons of golfer patients, but try and get on the course early. The sun is most intense, usually kind of from those midday hours, so 10 to 2 in that range. And obviously in the summertime months, it's going to be higher overhead, and so it's more intense then. So try and plan your activities accordingly. Physical protection, so wearing hats, baseball caps, and then sunscreen. And I'm always asked, what's the best sunscreen, all that sort of stuff. It's what you got to use it essentially. So it's really important just to find one that you'll use, and we can get into the nitty-gritty if you want of the differences between sunscreen and SPF and when and how to apply. But your basic minimizing skin cancer and aging of the skin, sunscreens, protective clothing, and then time of day for activities.
Let's talk a little bit about SPF, just a little, because we're running out of time and there's a couple of other things we want to hit on. But what SPF, 45, 35, 50? Is it what do you suggest?
So again, you got to make sure you're going to use it. I mean, you could have an SPF 10,000, but if you're not going to put it on, it's not going to do anything.
Right.
Okay? As a quick sort of easy rule, 30 or above is going to be good. Okay.
Perfect.
You want to look for broad spectrum. Okay. So most are going to be broad spectrum, and then depending on your level of activity and water exposure, waterproof or water resistant. With waterproof not wearing off less easily than water resistant. I like to break sunscreens into the chemical blockers versus the physical blockers. And the physical blockers, there's really only two, titanium and zinc-based ingredients. They work literally by reflecting or blocking the sun's rays, okay?
Do they work better?
They do, they do. There's a little downside to them, but they tend to,
Like
they
you
tend
look
to have
like
a broader
Casper.
spectrum. Yeah, that's, especially with the zinc. There's better formulations now. Chemical blockers are when you look on the active ingredient of a bottle and you can't pronounce the name. So like avobenzone, octocrylate, there's a bunch of different ones there. They work by converting the UV radiation into heat. So they don't reflect it, but they convert it, okay? Usually those don't have a full broad spectrum alone, which is why you'll often see 4 or 5 different ones of those.
Okay.
So they each kind of have this window that they work on, and so they mix a bunch of them together, and so that it ultimately overlaps the complete UV spectrum. Those are common, and they rub in. I like the zinc or titanium base because A, it's 1 or 2 ingredients that blocks everything. B, they're very, very effective, and they tend to last a little while longer. The downside, like Kevin said, as you get to a higher percentage of those, it leaves a little bit of that white film. Now, there are different ways to package them and formulate them that's better. So I will tell patients, pick it based on the occasion and the time of year. You know, if you're just going about your day-to-day activities in January, you can use something that's kind of thin and light. You don't need crazy, protection. If you're surfing in Costa Rica in July, you should look like Casper. Like you should look like a full white paste across your face because the sun is that intense at that point, and have a hat and everything.
And the frequency with which you need to reapply it depends on not only the type,
correct,
but also
what you're doing,
what activities you're doing.
I mean, you'll see oftentimes 2
and,
hours.
And the SPF, right?
And the SPF, your level of water exposure. But if you put on one of those thick 20% zinc sunscreens, I mean, you surf for a couple hours, you still look like Casper. So that's how you kind of know it's still working.
I have a hat that has SPF.
They'll call them UPF in clothing.
Exactly.
UPF, but it's a similar mechanism.
I like it.
Yeah. Well, really quick, because we're running out of time.
Go for it.
So let's talk a little bit about acne.
Sure.
For youth, and
But they say for me.
yeah.
Like,
For the youths.
am I breaking
For the
out?
youths. Acne is a huge thing that happens, high school, college. My son's going through it. My friends' kids are going through it. Is there any key things that you can tell us, and particularly us moms, about acne for your grown kids?
Acne also is very genetically driven, right? So not every teenager gets acne, but some do, and some do very severely, and they'll relate it back to a parent or sibling. And it tends to be hormonally driven, so that's why we see it in the teenage years. And it can vary greatly in severity, a couple zits to debilitating, scarring acne that leaves those signs for life. And acne scarring is very difficult to treat. I think you probably know too. Later on, the best treatment for acne scarring is not to get it, is to prevent it through medical management prior on. So how we treat acne, there's a lot of different ways, and so much of it depends on severity and also how reliable the patient is going to be in their treatment. A 14-year-old may not be able to handle a regimen involving 2 or 3 creams and a pill.
Right.
So we will try and simplify things. Usually for mild to moderate acne, we'll start with topical treatments, usually a retinoid, like a Retin-A, which helps kind of unclog the pores at a cellular level, and some sort of topical antibiotic, usually something like a clindamycin or benzoyl peroxide. From there, as you increase intensity, you can go to oral antibiotics, usually not just like a course you would take for a strep throat, but months and months of oral antibiotics. Oral retinoids, which is like your Accutane, that's kind of your big gun, or hormonal treatments. And hormonal treatments have gained a lot of popularity, not just for treatment for acne, but a lot of women will have acne in their teens and then it kind of goes away for their 20s, and as they hit their late 20s and early 30s, they start getting it again, and that's very hormonally driven, so we'll kind of shy away from your traditional treatments and go more towards hormonal treatments there.
What about lifestyle choices, especially for teenagers? I mean, I'm constantly telling my daughters, like, don't touch your face, don't pick your face. I mean, like, how much of diet and just daily lifestyle choices apart from the chemistry of it?
It affects it. There's not, I can't say like, avoid chocolate or avoid pizza or something like that. There's not going to be a specific food, but acne is at its heart an inflammatory process, and the amount of inflammation in the body is affected by your lifestyle. And it's an easy answer, but it's kind of a harder thing to implement. Healthy lifestyle choices. So eating a healthy diet, getting regular routine sleep, getting regular routine exercise. Yeah, not for teenagers, but not smoking and drinking, things like that. Very basic lifestyle choices that we all kind of know already, but may not necessarily do.
I'm going to put this on a loop for my kids. And play
go
it
to
for
sleep.
them at night. Go to sleep.
I'm a huge advocate.
Stop eating junk food.
Yeah, I'm a huge advocate of sleep and sleep hygiene. I think it still is very, very underrated in our society today in terms of getting very, very regular routine sleep. And that, again, will bring down just the overall inflammation in your body. And so, and then if they're, like picking and things like that, we don't like for acne as well. Don't try and pop your zits.
That explains why you look so much more rested than me.
Yeah. Don't forget I have 3 little ones at home, They will keep me up.
All right, so we're like heading toward the end here.
Sure, yeah. What do you want to finish?
One question that I like to ask my guests.
Okay.
It's not difficult.
Okay.
It's not like SAT level.
No worries.
Had you not gone to med school
and
become a dermatologist, what do you think you would have done with your life?
Probably a failed sports broadcaster or something. I love sports of all types. My patients have to hear me talk about inane sports stuff all the time. So I don't know specifically what in that industry, but I probably would have pursued something in the realm of not professional athletics, but maybe management or something like that.
That's cool.
Awesome.
I like that. It's different.
Well, also really quick, we want to hit on all the articles that you've written.
Sure.
You've also written, why don't you tell us a little bit about stuff that you've
book
written?
chapters.
Book chapters.
Journal articles, peer-reviewed articles.
Yeah.
Mostly about skin cancer, right?
Yeah, I mean, look, I started publishing in, I think my first publication was at the end of undergrad. I was a neuroscience major. I did some research. I was at Virginia, but I did some research for NYU. That was my first publication. And then through medical school, I actually was going to be a plastic surgeon, so a lot of my early publications were in plastics, but I kind of changed routes to do
You kind
those.
of are a plastic surgeon.
It's different style, but yeah, it's very similar.
Different route.
Yeah, different route, exactly. So I have a lot of publications in plastic surgery, mainly reconstructive. I have some stuff on craniosynostosis.
I wrote a paper on
craniosynostosis.
It was a case study, actually.
Could have overlapped at some point.
Maybe we could have co-written for each other.
And then I did all my training at UCLA, and it's a big transplant center. So, and this is sort of a random aside, but transplant patients, because of their immunosuppression, and we didn't talk about how the immune system plays a role in cancers, but specifically skin cancers. So a lot of publications on skin cancers, specifically in the transplant population, and how we manage and treat those. So yeah, and that's some cosmetic publications as well. I do some cosmetic work and did quite a bit in fellowship and published on that as well. So it covers the spectrum as my practice has over the years, but has kind of focused to what my practice is focused on, which is mainly skin cancer.
Skin cancer, derma fillers, Botox, all of that. Okay, great.
Everything. He's a jack of all trades.
I
in the
love it.
dermatology world.
I think I'm going to have to come visit you.
Well, Dr. Breithaupt,
Yep.
Andrew, thank you for coming on.
Of course.
Appreciate it.
Yep.
I think this will be very informative for our listeners, for our viewers. Before we completely wrap up, we're going to have you just tell everyone, just look at the camera and just tell everyone how they can get a hold of you.
Sure.
If they're like, oh my God, my mom needs Mohs surgery and I can't find a good Mohs surgeon.
So I have practices actually 3 different locations in Southern California: Beverly Hills, sharing the office with you, Torrance, California, and Newport Beach. Easiest way to find me, either Google my name or derm90210.com. That's the website for our Beverly Hills office, and you could contact me there. I'm not on social media. My wife runs the Instagram, so I don't have a handle or anything there. But yeah, Google my name or derm90210.com.
Or call my office.
Yeah, I'll call the office.
And
We'll get you over there.
Yeah.
All right, awesome.
Well, thank you so
Yeah,
much.
of
Thank you
course.
so much.
Yeah.
I learned a lot this episode. Dr. Brenner's like, you're
You're a theoretical doctor.
yeah.
Test at the end of the season.
Well, thank you, and
That's it.
yeah.
Appreciate
All right.
it. Appreciate it.
Okay.
Thank you guys for watching and listening to this episode of Beyond the O.R. with Dr. Andrew Breithaupt, our wonderful dermatology Mohs surgeon guest. Don't forget to like, follow, and subscribe on all of your platforms. We'll see you next time. Thanks so much for listening to Beyond the O.R. with Dr. Brenner. Make sure to subscribe, like, and follow so you don't miss any future episodes. In the meantime, hit me up on Instagram, Twitter, and TikTok at Kevin Brenner MD and KevinBrennerMD.com.